I think we have had a good introduction to TB from Niranjan and Mudita. So I will get straight to the point, and just to sort of recapitulate what Niranjan has said, we have TB is a major problem, and it's spread by the aerosol route. And therefore, if you have a patient with TB, it can spread to others. And the main thing is that about a majority of people have an initial containment of the disease, 95% or so, and of course 5% may get the disease. And then, as Niranjan nicely said, of these patients, 90% may actually self-cure yourself. So most of us hopefully have self-cured ourselves during our careers. And then, of course, you have this latent TB, and these patients, these people can get TB later on, about 5% there. So if we want to eradicate TB, we need to stop these 2 points. We need to stop the infection of others. And of course, we need to stop this latent TB, and we'll be discussing this later on. And I'll be discussing the management of the patients who have tuberculosis. So as you know, it involves mainly the lung, but it can involve any organ. And I will just take some clinical scenarios. Scenario number one is Miss A, age 25 years, employee at a garment factory, presenting with a cough, shortness of breath, and fever of 1 week duration. And on further questioning, she had an on and off fever. And this is very important. When you take the history, sometimes you get only a very acute history. But if you go for further questioning in these patients with TB, you find that for the last 2 months, she has been feeling feverish, having on and off symptoms, loss of appetite, loss of weight of 2 kilograms, febrile, and on examination, she's febrile, wasted, with cervical lymphadenopathy. And you look at the chest, you get trachea elevated to the right side with right upper zone bronchial breathing and crepitations. No past history of TB or contact history of TB. So with this scenario, we are thinking of TB. What are the clinical manifestations of TB? Cough is one of the major symptoms of TB, but of course, fever is quite common in them. Sometimes you get a high fever, but in the majority, you get a mild fever, night sweats, weight loss, malaise, and these are probably cytokine related. And you get sweating, profuse sweating in some patients, and night sweats are quite common. Hemoptysis, chest pain, and shortness of breath are also quite common symptoms. Think of these, and you think of TB. Differential diagnosis is very wide. Many respiratory symptoms, respiratory diseases will actually give rise to possibility of TB, and of course, cardiac diseases and many other diseases. So when we are classifying TB, we would be actually thinking of, so we have this patient who we think of is having TB. We do the, as Dr. Mudita mentioned, we'll do the sputum AFB. Sputum AFB is positive. Then we need to, before that, we need to classify this patient. Is it a pulmonary TB or is it extrapulmonary? So pulmonary is the lung involvement. If it is pleura or any other organ in the body, it becomes extrapulmonary TB. And in pulmonary TB, you would again classify these as bacteriologically positive TBs and bacteriologically negative. So bacteriologically positive will be either smears, gene expert, cultures. Any of those tests being positive would be bacteriologically positive patients. Now, in our patient, the sputum is positive. Patient has never had TB before, and then you classify these patients as a new case. And these are actually patients who have never had TB before or had less than 1 month of treatment previously. So how do you treat these patients? New patient treatment, we start with the classical 4 drugs, the rifampicin, isoniazid, pyrazinamide, and ethambutol. We give that for 2 months, followed by a 4-month regime. And we are now fortunate we have the fixed dose combination, so we don't have to give a large amount of drugs. We have the combination therapy. I hope you can see some of this, but so the diagnostic algorithm which we follow in these patients is that when we have a new case, we start the patient on HREZE, And and at the end of 2 months, we do the sputum. And at the end of 2 months, if the sputum, initially the sputum is positive, at the end of the 2 months, the sputum is negative, then we go on to the continuation phase, where we give the regime of isoniazid and rifampicin and recheck the sputum at the end of the 5th month and at the end of treatment. And we do a chest X-ray there. If it is negative, then of course we classify this patient as cured. As Niranjan said, these people can be having some bacilli, but usually we classify them as cured. But if the patient at the end of 5 months or end of 6 months is sputum positive, then we have to reclassify these patients as a treatment failure and then go on for further treatment. Well, if the patient is positive at the end of the 2nd month, sputum is positive, then we continue the isoniazid, rifampicin, ethambutol, and pyrazinamide for another 1 month. And at the end of 3rd month, we examine the sputum again. And in the meantime, we will do, in the new diagnostics, we will do a gene expert and a TB culture. What we are looking for is this multi-drug resistant TB, or is it a typical organism? Because in the sputum positive patients, we have not done a culture initially in our regime because of our constraints in diagnostics. So at the end of the 3rd month, if the patient is positive or negative, we can go on to the continuation phase, but always take a culture sample and of course a gene expert. Then we go on to the continuation phase of 4 months of isoniazid and rifampicin, and again examine the sputum at the end of the 3rd month and the 4th month of the continuation phase. If it is negative, we have cured the patient. We classify as cured. But if it is positive, then of course we go for a retreatment regime. Now, that is a new patient coming with TB. Now, this is clinical scenario number 2, where male age 55 years, presents with a productive cough of 2 years, worse over the last 2 months. He has diabetes mellitus, which is poorly controlled over the last 3 months. And he has been taking alcohol, and he's a smoker. He has hemoptysis and fever with loss of appetite and loss of weight, chest X-ray worsening, right upper zone shadowing, and sputum AFB is 2+. He has been treated for TB 10 years back. So he has a lot of risk categories. Of course, when you think of risk categories for TB, if you're breathing, you can get TB. So many patients come in, when we say about TB, they say, nobody has had TB in my whole generations of these things. So of course, if you have not died, then you can get TB, right? So if you're breathing, you can get TB. But of course, if you're smoking, if you have alcohol, diabetes, immunosuppression, steroids, malignancy, or being a close contact of a highly positive patient, then you are at higher risk of developing tuberculosis. So in this patient, this is a positive patient. He has been previously treated, so we treat it as a relapse of TB. The other classifications which we would do is, of course, treatment after failure, and then, of course, and if the patient defaults treatment for more than 2 months, we classify them as lost to follow up and restart treatment. So in this retreatment regime, we go for a 3-month regime of isoniazid, rifampicin, and ethambutol and pyrazinamide. Earlier, we used to give streptomycin to this patient. Now, streptomycin has been phased out. So we go for the 4 drugs for 3 months. We do the sputum, and then we go for the continuation phase of rifampicin, isoniazid, then ethambutol for another 5 months, a total of 8 months. So that is the retreatment regime. And what we do here is, so end of the 3rd month, we will do the sputum. If it is negative, we convert them to the continuation phase of the 3 drugs. And at the end of the treatment, if he's sputum negative, then he's cured. If he is positive, then we will go for end of 5th month and end of 6th month. If he is positive, end of 8th month, if he's positive, then we reclassify them and treat them as a failure. We need to review these patients to see whether they are having MDR TB, whether any other complications exist. So that is the negative pathway which I discussed. And then, of course, if they are positive at the end of the 4th month, if they are positive at the end of the 3rd month, we go for another extended 1 month. And then you re-examine the sputum. You will do, if the sputum is negative, you will convert them to the 5-month 3 drugs of isoniazid, rifampicin, and ethambutol. And then you would go on. You go on to and examine the sputum again at the end of treatment. And if they are sputum negative at the end of treatment, they can be cured. They are cured. Okay. So case scenario number 3 is a 45-year-old male smoker complains of dry cough, shortness of breath, and chest pain of 2 months duration. He has some loss of appetite. He's not very sure whether he has loss of appetite. He's not very sure of his loss of weight. No past history of TB. He has been feeling feverish. He's not very sure whether he has fever or not. And he has signs of collapse, fibrosis on examination in the left upper zone with bilateral vessels. No lymphadenopathy or clubbing. Fever chart shows mild fever spikes on and off episodically. And these are some of the patients who come in with this problematic appearance. His ESR is 100, white count is 11,500, some just a little bit high. Sputum AFB is 3, is negative, mucopurulent samples. Chest X-ray confirms, you can see here, left upper zone fibrosis, plus or minus consolidation and some cavitation. MAN2 is 15. Sputum culture, there is no growth. Bronchoscopy is done on this patient, and inflamed bronchial mucosa is seen. BAL is done. It is negative. He started on anti-TB on clinical grounds. So clinically diagnosed tuberculosis is this patient's diagnosis. And so in a clinically diagnosed TB, again, we will go down this pathway. And in these patients, a culture is a must at the start of treatment. Even in patients who are retreatment patients, we should always do a culture at the start of treatment. We start them on 2 months of HREZD, and we review their chest X-ray at 1 month and 2 months. If there is no response, you need to review the diagnosis. You need to go for further investigations. You need to think of other causes, maybe malignancy complicating TB, or maybe malignancy alone may not be TB. And these sort of patients we also see quite often. And then we examine the sputum at the end of the 2nd month. If it is negative, we convert, we go for the continuation phase, and then we go for the normal treatment regime. End of treatment, if they are negative, then we classify them as cured, and always look for their chest X-ray. If it is not improved, we need to go for further investigation. But if they become positive, we need to always check their culture reports and trace their gene expert culture reports at the end of 2nd month. And if they are positive, then of course we may need to even reclassify them and restart treatment. We need to see whether this is a retreatment, we go for retreatment, or whether we can continue the treatment. So these patients are sometimes more complicated to treat, but we need to always keep an open mind whether it is TB plus some other disease, or it is TB alone, or maybe not TB, but something else. So when we are managing these patients, a very important aspect is to prevent multi-drug resistant TB. DOTS has been in use since a long time now, since 1995. And it has these 5 components: political commitment at all levels. That is, political commitment is not only just political party commitment, but it is our commitment at every level: ministry commitment, chest clinic commitment, and at the DOTS provider level, at the commitment for the DOTS provider. If they are being treated at home, the commitment for the caregiver giving the treatment to the patient, all that commitment needs to be there. And this is a very important aspect of case holding the patient over the 6 months or even further if you are treating these patients. So adequate supply of drugs, adequate supply of diagnostics. We still have a good supply of sputum AFB is widely available around the country, but gene expert facilities, we have had breakdowns even in Kandy, and line probe assay we had earlier 10 years back when we had line probe assay. We don't have line probe assay for the last 5 years. So we have gone back actually. So we are having problems. And of course, case holding is very important. Directly observed therapy, where somebody who is accountable for the patient, accountable to the system, gives the drug to the patient daily, and accountability is very important in these patients. So always look for this. So in summary, I think the main message here is, as Dr. Naranjan also mentioned, we are going for eradication of TB. If we need to be for going for eradication and protection of ourselves, we need to treat and cure these patients. We need to find the patients whom we are missing. As Dr. Naranjan pointed out, we are missing a large number of patients in our community. We need to find them, treat them adequately, and then, of course, we need to prevent MDR-TB, and thereby we can eradicate TB from the world and in Sri Lanka. Thank you very much.